Bismillah ar-Rahman ar-Rahim. I'm going to take you a little bit away from heart and lung for a few minutes to a new organ in the holistic approach, which is diaphragm ultrasound and the current evidence. I have no conflict of interest apart from being Saving Lives Academy founder and CEO. I would like to thank Rashid Tayyar for his high quality videos he supplied me with compared to the low quality ones I did have. At this talk, we're going to shed light on the different causes of weaning failure in ICU with the special focus on the diaphragmatic dysfunction in critical care and magnitude of this problem. We'll quickly go through the different methods of diaphragmatic dysfunction assessment with focus on the role of ultrasound, including the few tips and tricks. You're gonna make a lot of benefit using them, ending up by what is the current evidence of using ultrasound in assessment of diaphragmatic dysfunction and its value in weaning from mechanical ventilation. You can classify the causes of weaning failure in ultrasound in critical care by two different techniques, which the first one is pulmonary versus extrapulmonary, or the preferred method to myself, which is A, B, C, D, E approach. A is for airways, and there's a lot of lung ultrasound modalities using ultrasound to assess for airway edema. I don't do that myself, but stridor versus laryngeal spasm in the upper airways compared to the lower airways, like something like asthma or increased airway resistance, including breathing, which is lung parenchyma versus the bony skeleton. So you can say B for breathing or bony skeleton. That's just a mnemonic. Use it if you wish. So lung parenchyma, it could be pneumonia, atelectasis. The bony skeleton can be assessed clinically by presence of fractures causing hypoventilation because of pain. Cardiac is the C. So heart failure, which is systolic heart failure or diastolic heart failure, or heart failure with preserved ejection fraction, the new terminology, and worsening of pulmonary edema post-extubation, which may need some diuresis beforehand to minimize the incidence of reintubation. Going from the C to the D, which is diaphragm, and this is the lecture of today. E could be effusion or electrolytes like pericardial effusion, pleural effusions. Both increase the incidence of reintubation after extubation. Electrolytes supplementation. I would thank Professor Antoine Villard-Barrault at this stage and his colleagues who wrote a very nice review article on this approach, the ABCD approach. I strongly recommend that you quickly download this one and go through the steps and details of the article. So let's go straight forward to the diaphragm. Diaphragm is composed of two main components, the central tendon and the muscle. It is supplied by C3 to C5 cervical nerve roots, and it is responsible for around 3/4 of the breathing effort or respiratory muscle share of diaphragm is around 75%. So diaphragm dysfunction in ICU is the common problem. Yes, it is. So what is coming from? It could be coming from the central nervous system diseases, something like amyotrophic lateral sclerosis. It could be from phrenic nerve involvement, like severing or compression, or it could be a nerve block, like in post-cardiac surgery, which is 30 to 75% of the cases has diaphragmatic paralysis because of phrenic nerve block, with a strong clinical impact on the patient's outcome in this stage. If you're coming from an anesthesia background, supraclavicular and interscalene blocks in COPD patients is something contraindicated because it is well related to diaphragmatic paralysis or diaphragmatic dysfunction and may lead to mechanical ventilation, and that could be prolonged. Motor neuron disease, neuromuscular or neuromuscular junction disorders, hypothermia, and traction of the phrenic nerve are all causes of diaphragmatic dysfunction either in post-anesthesia or in critical care. So a nice study by Alexander and colleagues published 7 years back in the American Journal of Respiratory and Critical Care, it shows that diaphragmatic dysfunction, which is defined at this stage as reduced capacity of diaphragm to produce a negative intrathoracic pressure in response to phrenic nerve stimulation, is frequent and in most commonly in intubated patient, in critically ill intubated patient, and is also associated with a poor clinical outcome. So that's a fact. Now, that's 7 years back and well-established fact. Uh, the last 2 decades, the pathophysiologists were seeking why and what is the reason of this diaphragmatic dysfunction in ICU, particularly in ventilated patients, with multiple underlying factors involved. So you can go for this scheme and find there is a lot of pathways. The most common pathway out of these pathways is the ubiquitin proteasome pathway. And I quoted from this article, which is freshly published a few months ago, some factors that hasten and hasten the activation of these pathways, something like age, type and duration of mechanical ventilation, nutritional and metabolic status, other comorbidities, particularly sepsis and diabetes, using glucocorticoids and use of neuromuscular blockers. All these hasten the process of diaphragmatic dysfunction, so please try to avoid that in ICUs as much as you can. In this very interesting study published in the American Journal of Respiratory Critical Care, showing on the left-hand side the hematoxylin and leucine and immunohistochemical stain on the right side, comparing the normal diaphragms again on the left side with diaphragms of critically ill patients on the right side. So here, this is a normal diaphragm with hematoxylin and leucine stain, and this is a diaphragm of the critically ill patient with multiple macrophages, neutrophils, granulocytes, significantly higher in the critically ill patient compared to the control diaphragm. And this is the same by immunohistochemical stains showing the critically ill patient with a lot of macrophages and neutrophil granules compared to the normal diaphragm. So here let's go to the weaning process. What we know and we are confident about today is that the weaning failure carries higher and worse outcome, higher mortality and worse outcome. Yet the best weaning modality is not well known. So the fact is higher mortality, but how to improve this one is not well known. So as you had seen over the last couple of days, that weaning failure is complex and may be caused by different etiologies and different mechanisms. So the question we want to answer today is the ultrasound diaphragm helpful in decreasing the mortality and morbidity related to the weaning failure? As per the current evidence, this is that we want to know today. So assessment of diaphragmatic dysfunction, a lot of modalities were used like chest X-ray, which is having good sensitivity but very poor specificity, 44%, transdiaphragmatic pressure or Gilbert index, as we will discuss in the coming few slides, fluoroscopic examination, electromyogram with phrenic nerve stimulation, MRI, pulmonary function testing, NAVA, a lot of modalities. So transdiaphragmatic pressure idea is, which we call the Gilbert index, is the gold standard, but still has a very poor sensitivity. How to do that? There is 2 balloons. One is in the esophagus, and the second balloon is in the gastric or in the stomach, reflecting the intrathoracic and intra-abdominal pressure respectively. So the thoracic one is the one in the esophagus reflects the intrathoracic pressure, and the gastric one reflects the abdominal pressure, and then you measure the difference between both of the intrathoracic and intra-abdominal pressure, and this is what we call the Gilbert index, and we'll discuss that in the coming few slides. But it is the gold standard. So let's go to the ultrasound diaphragm and assess how to do that. What's the technique? So how to perform your measurement. The probe that we use could be the linear probe, the curved or abdominal probe, and phased array probe. All of them can be used. The preferred method of measuring the thickness and thickness fraction is the linear or vascular probe. You can assess the diaphragmatic excursion or mobility or movement using the curved abdominal probe or the phased array probe, and you need to put your probe at the line or the point or the zone of opposition, which is the point of insertion of diaphragm in or meeting of diaphragm with the intercostal muscles, and this is 8th to 9th or 9th to 10th, so roughly the side of putting my probe is 8 to 10 intercostal space in the mid axillary to the anterior axillary line. Okay, so let me give you a few tips from my own practice that helps a lot to improve your image quality and your measurement. The depth of your ultrasound beam should be adjusted to the level that you need, so don't waste your ultrasound waves. The more deeper you go, the more ultrasound waves you need. So if you need 50% of your image, don't go to higher level of depth. So optimize your depth. Zoom on the diaphragm and always zoom when you are taking any measurement if you can. So you minimize the errors in your measurement because you improve your zoom, you can see better. Focus your beam, so there is a focus that can go up or down in your field. Focus your beam at the level of the diaphragm or just below, but definitely not higher. This improves your visualization of the accuracy of your visualization of the diaphragm. Optimize your gain so you can clearly visualize the deep field exactly the same as the superficial field, because you need to assess in diaphragmatic excursion, so you need to see the deep field as well. Very important point in your documentation, and particularly if you're doing a research work, you have to standardize the position of the patient. If you're making the patient pre and post spontaneous breathing trial, you have to make your position, your patient position as a standard. Are you doing that in 45 degrees or flat or sitting or semi-sitting? You have to make it very standardized in this occasion. You can see diaphragm by ultrasound and assess it in two different modalities, quantitative and qualitative. Let's start by qualitative approach. So there's three different videos. The leftmost here is showing a phased array probe focusing on this hyperechoic structure, which is a diaphragm. The patient head is towards the left, the patient feet is towards the right of the image. So this is the lung, and as you see here, I cannot see the spine sign, so I can see a hyperechoic structure just posterior to the liver. So this is the diaphragm. Okay, so second image here is a bit zoomed image with a linear probe, as you see here. So linear probe gives you a more focused image, and this is the line or the zone of opposition, the insertion of diaphragm in the intercostal muscles here, and this is a zoomed view. And here you can compare the no movement or almost no movement or very subtle movement of diaphragm compared to what looks like a normal or good movement. I can say good movement in these right two images here. So that's very good. And you see here the thickening at the end of inspiration of the diaphragm. So what's normal versus abnormal? So as you see here, again, this is the line of opposition. Diaphragm thickens at the end of inspiration. So remember the rule that the muscles get thicker in contraction compared to relaxation. So during inspiration, the diaphragm contracts and goes down and thickens towards the end of inspiration. So normally the thickness of the diaphragm is 1.5 to 1.9 millimeters in the relaxed end expiratory, compared to 3.6 to 5.4 millimeters at the total lung capacity or at complete contraction. That's how we measure diaphragm thickness in both tidal volume and in full or deep inspiration and total lung capacity. And as you see here, This is a zoomed image from the left to the right. So this is a 2D mode using a linear probe focusing on the line of opposition. Again, why we zoom on the image? To minimize the errors of thickening or the measurement. So whenever you take any measurement, try to minimize the error by making zoom as maximum as you can. So let's have another look on a patient with a diaphragm that's phased array probe. This is the head towards the left side of the image, the feet towards the right side of the image. And as you see, it's almost static diaphragm. Diaphragm is showing absolutely almost no movement here. So let's go to the qualitative. So if we're talking about qualitative measures, we need to mention numbers. So we'll go for diaphragmatic excursion, which excursion means the mobility or the movement of diaphragm between inspiration and expiration. So normally it's 15 to 25 millimeters, and we consider the diaphragm has severe dysfunction if it is less than 10 millimeters or 1 centimeter. So the maximum excursion shows a very good correlation with Gilbert index. As we said, the Gilbert index is a difference between pressures in thoracic and abdominal reflected by an esophageal balloon and abdominal balloon. So the difference, if the difference is 0, so there is no transdiaphragmatic pressure change. So delta pressure or delta pressure change in Gilbert index, if it is equal or less than 0, that means there is no diaphragmatic movement. And the normal Gilbert index is more than or equal to 0.3. So value of 0 reflects no movement, so there is no pressure changes between thoracic and abdominal pressures at the end of inspiration. So there is a good correlation with the gold standard, which is the Gilbert index, if we are talking about diaphragmatic excursion. Diaphragmatic thickness, as we said during the tidal breath, it's 1.5 to 1.9 millimeters, and during the deep inspiration, it's 3.6 to 5.4 millimeters. And we are talking about thickness, so we are using millimeters compared to the excursion, which is here like 25 millimeters, which is 2.5 centimeters. So if we're talking about excursion, we're talking in centimeters. If we say 1.5 and 2.5, here 1.5 millimeters to 1.9 millimeters, this is the thickness, and 3.6 to 5.4. So there is another element we use, which is the thickening fraction. This is if you take the thickening maximum during inspiration and you subtract from it the thickness in the minimum, which is during expiration, and divide that by the minimum, which is thickness of diaphragm at the end of expiration again, you will get a thickening fraction, which is one of the promising tools in assessing diaphragmatic dysfunction. So thickening fraction is normally greater than 20%, and reduced thickening fraction can be shown good predictor of the weaning failure as per the current evidence, and we'll see that now. So diaphragmatic excursion can be measured by a phased array probe, the same idea of the TAPSE or tricuspid annular plane systolic excursion. So you just use the same software. That's the value of the phased array probe. So as you see in this image, you put perpendicular to the diaphragm and measure the excursion or the mobility. So you can measure 2.1 here, and as we said, it is because it's excursion, it's coming in centimeters. This is 2.1 centimeters, so it's not thickening, so it's not in millimeters. So the diaphragmatic excursion is coming in centimeters, 21 millimeters or 2.1 centimeters. So the same idea of TAPSE, same software of TAPSE. You can measure the thickening fraction in 2D, as you see here in these right images, as well as the M mode, preferably to be done in the 2D. So here, this is the thickening at the end of inspiration and thickening at the end of expiration, and you can subtract expiration minus inspiration to get and divide that by inspiration. If it is 20% or more, that's good thickening fraction. So again, at the end of inspiration, minus end of expiration divided by the end of expiration to get the thickening fraction. And your cutoff for a good diaphragmatic contraction is 20% or more. Again, it's preferable to do that in 2D. The value of 2D is to, number one, to see the same measuring point, so you're not deceived by the M-mode position of the cursor, because you may be measuring at this point in inspiration and in this point during expiration. You want to make sure that this is the same point of measurement. If you get a negative movement during inspiration, that's a paradoxical movement, and this is a diagnostic for hemidiaphragmatic paralysis. And as we said, it's just another example of inspiratory thickening, expiratory thickening, and then see what's the difference and divide by the minimum expiratory measure, and then get thickening fraction. As you see here, another way to measure the diaphragmatic excursion, if you put your phased array probe and you put your measurement perpendicular to the diaphragm to measure the diaphragmatic excursion, it comes here as a 1.1, which is on the lowest normal or severe diaphragmatic dysfunction is diagnosed when it's 1. So at this measure, you can find 1.13, almost static diaphragm. So diaphragm here is extremely weak diaphragm with no good diaphragmatic excursion. If you compare that to what's normal, so during tidal breath in the top image here, and deep breath, and you can measure diaphragmatic excursion here. So look at tidal breath and deep breath. So you can compare those ones normal to this one, which is like very flattened diaphragmatic excursion. So this is how we quantitatively and qualitatively assess diaphragmatic dysfunction. Now let's go to the current evidence on assessment of diaphragm by the ultrasound. So assessment of diaphragm by ultrasound is long in history. So this is a systematic review published in the Intensive Care Medicine Journal on ultrasound use in diaphragmatic dysfunction, including 20 studies, a total of 875 patients. It's an observational or case controlled, which is a limitation of this study, using diaphragmatic thickness of 1.5 to 1.9 millimeters expiratory and 3.6 to 5.4 inspiratory, and diaphragmatic excursion range from 1.16 to 1.52 during the tidal breath. So the result of this study showed an excellent reproducibility between interclass correlation coefficient, which ranged from 0.87 to 0.99, which represented very good inter-observer variability, and from 0.56 to 0.98 as inter-observer variability, which is good figures. The only limitation to this systematic review is all the studies that were done were observational trials. No randomized control trial has been published so far for utilization of diaphragmatic ultrasound in critical care. Only one study, and we'll highlight it at the end of this talk. So another systematic review in the British Medical Journal by Kian and colleagues included 11 different studies on 436 patients. 8 studies were comparing diaphragmatic excursion, and 5 were comparing diaphragm thickening fraction, and 2 studies comparing diaphragmatic dysfunction between different groups with and without successful weaning. It includes, as you see here, 10 prospective trial and just 1 retrospective cohort study. There is high heterogeneity between the groups. What was used in this discussion was the diaphragmatic excursion and diaphragm thickening fraction with pooled sensitivity of 0.85 and a confidence interval of 95%, and pooled specificity of 0.74 with a confidence interval of 95%, predicting very good weaning success. That means, as per this systematic review, and meta-analysis, the diaphragm excursion and diaphragm thickening fraction has a good predictability of the weaning failure. Another systematic review and meta-analysis published in the Medicine Journal in 2018 on the prediction of weaning failure using diaphragm ultrasound, showing that diaphragm excursion sensitivity is 0.78 and specificity is 0.71 with a confidence interval of around 95%. And diaphragm thickening fraction is a little bit higher compared to diaphragmatic excursion, 0.89 sensitivity and 0.79 specificity. So here, as per this systematic review and meta-analysis, diaphragm thickening fraction carries higher sensitivity and higher specificity compared to diaphragmatic excursion. So the same concern in this study again is a large heterogeneity between the groups. So here comes the only prospective randomized, observational study done in 3 French hospitals over 20 months, including 191 patients who were at high risk as per their definition of re-intubation. So 33% of the patients, which represents 17% of the included patients, were considered extubation failure. And then they are comparing the two groups. So the proportion of patients with diaphragmatic dysfunction was similar between both groups. So as you see here, the box plot representation between those people failed with ultrasound assessment of diaphragm, showing the median 25th and 75th percentile, showing no significant difference between groups who had extubation success versus extubation failure. So values of excursion and thickening did not differ between the success and failure groups. So using diaphragm thickening and diaphragmatic excursion as the predictor of weaning success versus weaning failure was not a good predictor of weaning success as per this study. I was very careful reading this study and meticulously going through the lines, and I found some limitations which should be taken into consideration when you are putting these results into action. So the diaphragm excursion figure used in this patient was 2.5, which is on the higher side. That could be a confounding factor, where diaphragm thickening is using 20%, which was a good figure. But look at the numbers. The patient required intubation was 33, as I mentioned a minute ago. Those patients with hypoxia and hypercapnia was 9 and 3 patients only out of these 33 patients. Patient had upper airway obstruction were 2. Patient had shock as a cause of intubation was 7, and altered consciousness was 1. So we have 10 patients cannot be predicted to be intubation failure using diaphragm ultrasound. So 10 out of the 33. So take the figures carefully. Only hypoxia and hypercapnia were 12 out of these 33 patients. So which is very considered result if you look at the numbers and if you look into the details of this failure of weaning. There's a probable underestimation of anatomic variation of diaphragm insertion may have inferred with the exactness of diaphragm thickening assessment as well. Extubation failure was again defined as re-intubation need within 7 days or death. So including 3 patients that were put as a DNR, don't attempt resuscitation. Diaphragm assessment was again done towards the end of the spontaneous breathing trial, not at the beginning of the spontaneous breathing trial. So we should take into consideration all these factors before considering diaphragm ultrasound failed to assess for weaning. So the take-home message from this lecture that the weaning failure is a cause of mortality and significant morbidity and should be avoided by all means. That's no discussion about this one. Diaphragm discussion is a very common problem in intensive care patients with a lot of precipitating factors, including glucocorticoids use and muscle relaxant use. So try to avoid these ones as much as you can. Ultrasound is a good assessment tool for diaphragmatic dysfunction with a reasonably good sensitivity and specificity. We're talking about 70 to 80 and 80 to 90% in most of the studies or the systematic reviews done. Ultrasound use is a promising tool when it is used for assessment of weaning and prediction of extubation failure according to the current evidence available. There is a need for more prospective randomized multi-center trials to increase the current evidence level and supporting this new modality. So thanks very much for your listening, and your questions are always welcome. And I am sorry this is a retrospective recording because I did not record my lecture by mistake, but it was a technical failure from my side. So please accept my apology. And if you have any questions, please email me at contact@savinglivesacademy.com. Thanks very much.